And typical resistance you find in the older NNRTIs is a K103N mutation. Efavirenz has a very good pharmacokinetic, so a lot of people like to take it because it had a high forgiveness, but it has strong ZNS effects. I show later on some data about this. You see also dyslipidemia, and so there are also some disadvantages. Etravirine is normally more than one pill. There is no STR. It has also some drug interactions, but a different resistance profile compared to nevirapine and efavirenz. And riplivirine is very well tolerated in an RTE, but has a lot of drug-drug interactions, especially the interactions with PPEs with like pantoprazole is a big problem, because in Germany many people use this also medication over the counter. So if they use this, their riplivirine drug level is too low for efficacy. The other thing is it's not a very potent drug in patients with higher viral loads and low CD4 counts. It doesn't work very well, so it's only for persons treatment therapy, and antiretroviral therapy naive persons with low CD4 count or high viral load. It's not a good drug. So the other ones are more potent aspect of nevirapine. So if you see the chemical structure, you can see that there are the first generation, which generates if you have virological failures, key 103N mutation has these similar butterfly structure. The second generation has this structure, and the Doravirine, we know since 2018, has a different structure. So we expect that there is also a different resistance profile. And one second. And this is the horseshoe, and this is a different chemical structure. And if you look in the resistance testing from the laboratory, you see that a different resistance profile. The main mutation for resistance of doravirine is V106A, especially in combination with L234E or 108 or 227. And so it's expected that perhaps doravirine still works if riplivirine or efavirenz is already resistant after virological failure. I show some data later on to this question. So we have a different chemical structure and perhaps a different resistance profile. In Germany, we have different studies where we look for primary mutations in treatment-naive patients. And in this study from 7 university hospitals in Germany, we see 17.8 patients with drug resistance mutations. The most mutations were in the NRTI, more than 12%, but already 8.9% have mutations in NNRTI region, and there the most frequent mutation is K103N. And so far in Germany, you see here, the mutations against doravirine are really rare. So you have no problems in Germany to start in HIV positive persons with doravirine when they are still naive in treatment. Doravirine is once daily dosing so far. It is a potential victim of CYP3A4 inhibitors and inducers, but so far we don't see many interactions. It has no interactions with UGT1A1 transferase and OAT and OCT transporters, and also PGB modulators have no interaction. So you can have stable pharmacokinetics for Doravirine, and also in persons with renal impairment it can be used, and persons with moderate hepatic impairment. Here are some of the most frequent used drugs in Germany, and you see Doravirine compared with other single tablet regimens which are recommended in different guidelines has not so many interactions compared with other drugs. So there we can use it in many patients who have the most frequent diseases in Germany, like hypertonus, hyperlipidemia, depression, and something like that. It's also possible to use it together with contraception, and so there are not so many problems in the use of Doravirine with other drugs. This is, I start with the clinical research program, and you see here we have some studies with Doravirine, and there was a lot of criticism in Germany about the clinical program MSD or Merck have concepted for the development of Doravirine, because in the time they developed the drug, they only compare with drugs which are not recommended anymore in the European or German guidelines. For example, the comparator is efavirenz or darunavir, and both darunavir in the boosted format, not as Symptuza as a single tablet regimen, because it's not compared with any tough regimen. It's not compared with integrase inhibitors, and so the physician and experts expect that Merck or MSD concept a study to compare with the integrase inhibitor or with the combination with TAF, especially why Merck or MSD has Isentris, Dolutegravir as an integrase substance, and so it would be easy for them to compare this. So we have some studies, but with older drugs, so it's a part of discussion how we interpret this data. You see what I have told already, and from the phase 1 and 2 trials, they decide to use Doravirine for 100 milligram QD every day and start with this in the phase 3 program. The big studies for the phase 3 program are the Drive Forward study and the Drive Ahead study. The Drive Forward study compares Doravirine, it's a prospective double-blind randomized trial both, and they start with Doravirine 100 milligram versus placebo with 2 NRTIs. The NRTIs are of choice of the expert, the physician, and it's compared with Doravirine. Doravirine is compared with darunavir 800 milligram boosted by 100 milligram ritonavir, and also 2 NRTIs of choice of the physician. The patient should have a viral load over 1,000 copies per milliliter. No genotopic resistance to any study drug was allowed, and it was stratified by high viral load, lower 100,000 copies versus more than 100,000 copies. The same design was concepted for the comparator efavirenz. There, 2 single tablet regimens were compared with each other. also a multi-center double-blind randomized trial. And here, Doravirine combined with 3TC and TDF plus placebo was compared to Efficacy, 3TC, and TDF plus placebo in this prospective trial. And here you see the results in the phase forward study and also in the drive ahead, drive forward and drive ahead. The efficacy was 84% after 48 weeks. And in both studies, Doravirine was non-inferior compared to boosted darunavir and to efavirenz. And you see it was no difference if you look for higher viral loads. It was the same efficacy, and also a lower CD4 count has no influence on the outcome of the study. So it's also stable result for advanced patients. The discontinuation rate because of adverse events was low in the Doravirine arm. Over 48 weeks, only 2% interrupt the study in the Doravirine arm, and the most adverse event in the darunavir arm was diarrhea. And so Doravirine was a well-tolerated drug. In the Drive Ahead study, also the same, 3% discontinued due to an adverse events. And of course, what we expect, efavirenz makes much more psychotropic adverse events compared to Doravirine, like dizziness, abnormal dreams, and a high rate of rashes. I'm always, as a dermatologist, very surprised how many rashes were seen with efavirenz, and we don't have the same experience in our center. We have not so many rashes. The profile of the fasting lipids was much better for Doravirine compared to boosted darunavir. As we know from protease inhibitors, they can make higher lipids compared to other drugs, but also efavirenz have some lipid problems, and so you see a more famous lipid profile for Doravirine in these trials. When we have a virological failure, protocol-defined virological failure, a genotypical resistance test was performed. This happens in 4% of the Doravirine patients, in 2.9% of the darunavir patients, and in 6.6% of the efavirenz patients. And you see no resistance in the Doravirine, no resistance in the darunavir group, but you see some resistance in the Doravirine group. Lower than in the efavirenz group, 3.3% had a primary NNRTE resistance and 1.4 NRTI resistance, and you see 0.9% in the Doravirine arm have an NNRTE resistance and 0.8% in the NRT arm. So the resistance rate in the Doravirine arm is very, very low, but there is resistance if you have virological failure in the Doravirine treated patients. So putting the snapshot of the both studies together, in both studies 48% of the patients reach the aim of viral load below the level of detection. In both studies, this was non-inferior to the comparators, to darunavir boosted by ritonavir or to efavirenz. And very rare in 1.6, putting the NNRTE and the NRTE mutations together. You see in participants resistance if they have virological failure. And Doravirine was very well tolerated and safe. The neuropsychiatric profile was superior to effervescence, and the lipid profile was superior to effervescence and to boosted darunavir, and you have less diarrhea. So here, one case from our clinical practice we can discuss if you want with each other. We have a 54-year-old treatment naive man having sex with men. He has a high BME, has overweight, and he has a high viral load at his first HIV diagnosis, more than 100,000 HIV RNA copy per milliliter. He has a CD4 count of 276 pulse per microliter. He has in Germany the most popular subtype B of HIV, and so far no resistance mutations. But he has some comorbidities. He has a hypertension, hypercholesterolemia, and a depression, and he is already treated with candesartan and amlodipine against his hypertension, against his hypercholesterolemia. He gets atorvastatin, and against his depression, because he is sometimes sleepless, he gets mirtazapine. At the moment, he has no acute STI, he has no chronic hepatitis B or C, and so far he has no HIV-associated symptoms. And my question is, which initial RT regime would you choose for these patients? What would you prefer? What is your experience in Mexico City or Mexico?
I think that's the problem with Doravirine. We have no experience. But I think it's a patient with so many comorbidities, hypertension, hypercholesterolemia. I think some of drugs like Bictegravir, maybe DAF, could create problems in this patient. And depression, maybe, like your colleague Christian Hoffman presented in this year, I think, Dolutegravir and Bictegravir could be a problem. Then maybe we will think in another drug that maybe not integrase inhibitors.
Okay.
I think there is a physician who would like to discuss, Dr. Carmen.
Good evening.
Dr. Carmen, your micro is open. Okay, maybe not. Sure.
Okay, let us discuss this case. The first thing is the backbone. Abacavir is associated with the increase of myocardial infarction. So in the patient with hypertension, the patient is also smoker and hyperlipidemia. He has a high risk profile for cardiovascular diseases and events. So we wouldn't choose Abacavir as a backbone. And there is a lot of discussion about TDF in Germany and also in Europe about the guidelines. Tenofovir desoxyprivir fumarate is associated with a higher number of chronic kidney diseases, and this is older patients, more than 50 years old, and there we see more often also kidney problems. So perhaps this is not the best choice for this patient. The next problem is the risk of fracture, but he is a man and woman. After the climacterium, there is a high risk for osteoporosis. I'm not sure if this is the same problem in men, because the man is around 50 years old, but there is a higher risk for TDF. And TDF, but has a lipid lowering effect we don't see in TAF. And TDF makes no weight gain. You know the patient has already overweight, and you know that in a tough patient there might be an overweight problem, but you have less EGFR decrease, you have less frequent tubular proteinuria, and you have less decrease of bone mineral densities and less frequent hypophosphatemia. So there are some advantages for TAF, and we have to calculate it for each patient. What are the main problems? And there, the other point, Antonio, you already have discussed in your choice for this patient, and you know that efavirenz is associated in big cohorts with a increased hazard of suicidality. So you have more psychotropic adverse events, and this patient has a depression. So perhaps it's not a good idea to use this. The patient has a high viral load. Doravirine is not a very potent drug. So in patient with a lower CD4 count, I already mentioned, or a higher viral load, the efficacy is lower compared to other drugs, and it's not recommended for patients with high viral loads. So doravirine seems not to be the best choice. In protease inhibitors, we see high efficacy, but you see lipid problems, and the patient already takes atorvastatin and is overweight. And of course, you have a higher risk for cardiovascular diseases. So perhaps this wouldn't be the best choice for the patients. There is Bictegravir and Dolutegravir with high efficacy and no emergent resistance in treatment naive participants of the different studies. This is true for Bictegravir and also for Dolutegravir. And so this might be a very potent and good option for our patients. You have low rates of adverse events. So in many centers in Germany, integrase inhibitors are the preferred choices for the first treatment. And you see also there is a discussion about the dual treatment strategies. We have a single tablet regimen with 3TC and Dolutegravir called Dovato in Germany. And you see also it's a very potent and high efficacy drug in treatment naive patients. And you have and you have also good safety and tolerability, but it's not so much better compared to a 3-drug regimen. So you see in the European guidelines, in the recommended regimens, they only recommend integrase inhibitor containing regimens, and other combination therapies and single tablet regimens are also recommended, but only as an alternative regimen. Later on, I show you the actual German guidelines, and at the moment they are different from the European ones, and perhaps I can show with our case why we also need other drugs for the treatment of treatment naive patients. And here you see only the different integrase inhibitor combinations with different backbones are recommended as first-line regimens. So in our patients, the first antiretroviral regimen was Bictegravir, a TAF, FTC, and Bictegravir as the first regimen. And after 9 months treatment, the patient reaches a viral load below the level of detection. Also, the CD4 count increases, and as he has adverse problems, like Antonio already expect, he gets insomnia and he has a weight gain of 7 kilos. and he is not very satisfied with his regimen, and he doesn't feel very well, and he asks the physician, can we change anything? I'm not happy about the weight gain, and and he was not happy with the psychotropic problems. So here you, Antonio, you already mentioned the data of Christian Hoffmann, and you see a very nice publication of Christian Hoffmann, who collects a lot of data from different patients, real life patients with second generation integrase inhibitors, Bictegravir and Dolutegravir. And you see here that in many RCTs and also in real life, Christian Hoffmann also published data from real life, not only from RCTs. We see many patients with Bictegravir and Dolutegravir stop the treatment with these new integrase inhibitors because of neuropsychiatric adverse events. And so we know this from RCTs, we know this from cohorts for Dolutegravir. So far, we don't know from cohorts from Bictegravir, but you see in RCTs the rates of discontinuations because of neuropsychiatric adverse events are comparable between Bictegravir and Dolutegravir. So far, our clinical experience that there is not such a big difference in neuropsychiatric adverse events between Dolutegravir and other integrase strength inhibitors. There is a trend for a little bit less frequent neuropsychiatric adverse events for Raltegravir. The other point is it really true? What happens if you switch from Dolutegravir, for example, to other drugs? And you see from this data from Glagno from this year from the CROI conference, and they find in their cohort 4.5% discontinuations of Dolutegravir because of neuropsychiatric adverse events. And if they switch them, more than 60% have a complete resolution of these adverse events after the switch. So there should be an effect of Dolutegravir, and a switch can make sense for these patients to solve their problems with neuropsychiatric adverse events. The other data you know very well. It's a lot of discussion about weight gain since we observe some weight gain, especially with the new strength transfer inhibitors, Dolutegravir and Bictegravir, and compared with NNRTI and PI as the drug. And you see here the advanced study, a very famous study, very well published, New England Journal, showing a massive weight gain if you combine TAF with Dolutegravir. In women, the studies over 96-week, 10 kilos weight gain, and the weight gain was lower in women if they only use Dolutegravir, only 5 kilos. But in men, it's nearly the same, 4 kilos weight gain if you lose Dolutegravir with TDF, and 5 kilos if you use it together with TAF. And so the weight gain can be associated also in our patient with the use of Bictegravir. That there is a own effect of TAF you can see in the Discover trial. It's a PrEP trial for men having sex with men and other groups with a high risk for HIV transmission. And you see that there is a higher weight gain in the group of patients treated with PrEP, with TAF PrEP compared to TDF. I'm sure you know this data very well. So there is an effect of these drugs also in our patient. When he used Biktarvy, there is a TAF and Bictegravir effect on the weight gain. What happens if you use Doravirine? on the weight, and also you have from the European conference last year in Basel in Switzerland, where I also meet Antonio, and there you see they make an analysis of their post hoc analysis of the different treatment arms of the drive ahead and drive forward study, and they compare the Doravirine group with the Darunavir, boosted Darunavir and group and the Effervirens group. And you see there was a weight gain in all the three arms over 48 weeks, and it was over 96 weeks, 2.4 kilos in the Doravirine arm compared to the other arms. And if you look for this, if you look in median, it was 1 point in the Doravirine group. If you compare this with the general population in Germany, without any antiviral treatment, and you match it for age and gender, then you see that the average yearly change in adults, also without HIV, is the same. So far, Doravirine is not associated with body weight gain. So in Germany, our actual German-Austrian guidelines prefers single tablet regimens, but also have some drugs used with more tablets every day, but then as a QD regimen. And you see here, you have much more choice in Germany. We recommend, of course, integrase inhibitors, but also Doravirine for first-line treatment, and also Riplivirine and Darunavir, but Darunavir only in the combination with TAF, because we, in a great cohort analysis and growth reviews, we see that Darunavir together with TDF makes more kidney diseases, and so it's only recommended in the combination with TAF. So you see, Doravirine is also recommended as first-line choice in our patients, and perhaps it would be a better idea in the patient I have described to start with Doravirine, because Doravirine is not associated with neuropsychiatric problems, so the depression of the patient is not such a big problem, and not associated with weight gain, and it has a good lipid profile. So it might be a good choice for our patient I have described. And you see that perhaps more choice in the first line regimen still makes sense. And so not only integrase inhibitors may be the only best choice for our patients. Of course, there is always a discussion about TDF and TAF, and you remember 2 years ago, or perhaps you remember, or you know, that only TAF backbones were recommended in Germany. And since we see more data that TAF has also some adverse events, you can choose between TDF and TAF for the first line treatment. Now, in our patients, does it make sense to switch perhaps away from Bictegravir to Doravirine 3TC TDF? And what happens then with the lipid profile, and how's the efficacy? Here's some data from the drive shift trial. You see they like the prefix drive for the studies. And here you have a classical switch design of the study. You see one group gets an immediate switch to Doravirine 3TC TDF, and the other group continues with their regimen they get so far. Of course, all switch problems which are randomized are ethical problems, because normally there is no real reason for the switch, because ethically, if there is an important reason like toxicity, it's not ethically to randomize the trial. So the most patient switch studies, which are multi-center, open label, or randomized, are studies where the patients have no reason for the switch, so you can randomize them. And here you see also very good results, like expect. More than 90% were below the level of the detection. And you see a high efficacy, like in the most switch trials we see so far. If the patients are very well suppressed and have no resistance in their medical history, normally the drug works in the switch. And I'm happy to say that even in the patients with protocol-defined biological failures, no resistance was found in this trial. So it's possible also in our patients to switch. And you see here what happens after the switch. It's presented at the AIDS conference this year. And you see after the switch in 2 years, only a mean change of 1.2 or 1.4 kilos if you switch to Doravirine was observed. And so this is also it be observed in the normal adult population. And so also Doravirine use was not associated with weight gain in the switch setting. And if you look at the data about the immediate or delayed switch group, how develops the weight depending on the regimen used before the patient was switched to Doravirine, and the lowest weight gain you have in the strength inhibitor, integrase strength inhibitor group. So it can make sense if you have weight gain in patients who use integrase inhibitors, especially second generation inhibitors, to switch to Doravirine if weight gain is a problem in these patients. So in our patients, we also decide to switch these patients to Delstrigo, to TDF-3TC Doravirine, but we also offer the patients a sports program. He takes part from our AIDS aid. They go walking with patients, and they have also a program to advise a person how can they cook and what can they eat. And he also makes a diet and physical activity program. So he reached a weight loss of 4 kilos. So we can't say it's only the switch to Delstrigo the reason for the weight loss. Our experience is if you switch to Delstrigo, they don't lose any weight if they don't start any other activities like physical activity or a diet, but you can stop a further weight gain with the Delstrigo. But if you want to have a weight loss, you have to add other activities and other interventions, or you don't lose any weight. And the other advantage of the switch was he has less frequent insomnia, so the patient was more satisfied. The switch was not associated with any efficacy problems. The patient reached still a viral load below the level of detection. He has a further increase of CD4 cell count, and so he has no virological failure. And at the moment in our patient community or in our cohort, this one is one of the main reasons for Doravirine use. We also start with Doravirine TDF in patients with overweight or with neuropsychiatric problems. and this is one of the major indications for our patients. And we also switch some patients with weight gain, for especially if they use second generation integrase inhibitors. The other thing is we only decide to use this in patients who have no kidney problems or no osteoporosis. And especially in these patients, and it's also very good if they have physical activity to avoid osteoporosis. Okay, this was our case. This is one story. There are many other cases, but I want to show one case for our experience, or for a typical case for I want to demonstrate what's our experience or our main indication to you for the use of Doravirine. So far, are there any question or discussion about this?
Stefan, there is a question in the chat that says, in your experience, how many patients have with Doravirine plus TAF FTC? And what is the event of weight gain in the clinical practice? I think because we saw that you have in your German guidelines the combination of Doravirine plus TAF FTC. Maybe we don't know about the published data that how is
this combination works very well. We don't have as a single tablet regimen. It's still 2 tablets every day, and it's a very good regimen. It works very well, and especially in patient where you have kidney problems, but you have a higher weight gain compared to TDF. So far, TDF, you see also an influence of TAF in our patients. So if weight gain is a problem, we would prefer TDF. But if the patients have kidney problems, then TAF is better. So it's a decision very individual, depending on the comorbidities of the patient and the main adverse events and problems of the patient. But we have good experience at this. At the moment, in Germany, we have a very special situation because in Germany, TAF FTC is very, very expensive. Gilead makes a very high price. So we can't combine this with other drugs because it's not paid by the insurance anymore because of the exorbitant price of TAF FTC. And there's a lot of discussion about this, and it's a little bit fight about this. So we have many patients using this, but at the moment they have to pay for themselves. So this regimen is not very popular anymore because this is very expensive for our patients, and all the other measurements are paid by the insurance. So there's a lot of switch away from TAF, FTC, Doravirine. And many, of course, get then the combination TDF3TC, Doravirine, and we see also switch to other regimens, but this is our experience so far. So in the first question, the weight gain seems to be higher if you combine with TAF, Doravirine with TAF. And the other point is, but it's a very potent and very good regimen. If you don't have the same problems in Mexico we have in Germany at the moment, you can use very well. It's a very safe and regimen in our experience with a low rate of adverse events.
Thank you, Stefan. There is another interesting question. You talk about the good resistant profile of Doravirine. And a question is that if you know a study of, if you have experience with Doravirine, maybe combined with Darunavir, Dolutegravir in multi-experienced patients?
There is no good study about this, but we have experience in our center. We have every week a case conference because we are the center for the whole region, for also other HIV physicians, because we have here an interdisciplinary team. You can introduce your patient in this case conference if they have virological failure. And we have also virologists in our team interpreting the different resistance profiles. And so far, if you see the resistance, and for example, if the patients only have a K100 through 3N mutation, it's the most popular, the most frequent mutation we see in Germany so far when patients use NNRTIs, then you have a very good efficacy of, still a very good efficacy of Doravirine. But in some patients using NNRTIs, they don't have only the K103N mutation, then it can be critical to use Doravirine. So if you have much more mutations in the NNRT region, I wouldn't advise you to take Doravirine. If you only have the um, K100CN, it's a very good option if you need to create a new potent regimen.
Perfect. And finally, Stefan, regarding this clinical case that you presented recently, we had a talk with Dr. Paddy Malone, and he said that there is not a special way to change therapy, antiretroviral therapy, but he usually in his clinical practice change a patient that is increasing 10% of his body weight. In your clinical practice, where, for example, in this case that you increase, that you have a weight increase, you have some similar situation that more than 10%, or you prefer to take another kind of decisions regarding weight, regarding maybe metabolic syndrome?
Yeah, there. What is important to look for each patient? It's multifactorial reasons for weight gain. For example, also antidepressiva can make weight gain. So there are many reasons for weight gain, and but we don't. We discuss with our patients what happens with them, and for many patients in our clinical experience, I don't know what happens in your clinical experience, they always say, oh, it's a drug. They don't move anything, they eat the whole day, they smoke, and they have any problem, and it's always the antiviral therapy. And you can discuss with them for a long time, and even if they have the weight gain from 5%, they already are not satisfied with this and say, oh, I don't feel good. And then it can be a good option if you have for example, if the patient is very well suppressed, it's not such a big problem to switch and show the patient also with the other regimen what happens then. Perhaps it helps him psychologically if it's safe. So I want to show you can switch in these patients, and sometimes it's help to change the regimen. But I also want to show in our case here that if you only switch and the patient does nothing else, you don't see a weight lose. And also, if you change from, for example, Bictegravir or Descovy, TVK or what, and the patient doesn't change his life, perhaps you stop the weight gain, but we see no weight lose. But we don't have a point where we say now we switch. It's not fixed by 10%. It can be 5%. It's part of the discussion with the patient. And if the patient is very sad about his weight gain, we also start earlier to try this. And in Germany, I don't know how it's in Mexico. The price is very good of Delstrigo. So the costs are the same or even better with another regimen. So we don't have any problem with the assurance. And if the patient is compliant and has this wish, we discuss with him, and perhaps we decide also in patients who has a lower weight gain than 10% to try a switch.
Thank you, Stefan. If you want to move on to another topic, or
yes, I think what is always interesting for a drug, what future is planned with this drug, and I think there is a interesting development program of MSD Merck, and I only want to show that there is a new drug, islatravir. It's a new reverse nucleoside reverse transcriptase translocation inhibitor with a little different kind of activity. I want to start to say the resistance profile is not so different like the company promised us, but it's a different kind of action you can see here. And it's also the translocation of the nucleotide, and but there's also another kind of action. It's very hyped by the company, and so there is a new first in class islatravir, and it's used in the study. But what is interesting in the point of Doravirine, they plan a single tablet regimen, the combination of Doravirine and islatravir. And islatravir has a very nice pharmacokinetic profile. So it's possibly also a drug for long-acting strategies. So I only want to show the very preliminary data from AIDS this year. This is a phase 2 study where they make to find the drug concentration you need for efficacy trial phase 2 for the next trials, and they use 0.25 milligram, 0.75, or very high doses 2.25 plus Doravirine, and they compare with each other. You see a good efficacy in the most arms. What is very interesting that the arm with the highest dosage seem to have some problems with efficacy. So we are interested how they are going on with the development program. But at the end, in the other arms, the patients reach a viral load below the level of detection of around 90% in 48 weeks. And so we see it's so far very well tolerated. So it might be a new option. And they directly look for rate gain in the patients, and it's very preliminary data, and we know it's not so far how it's going on. But it's very interesting that Doravirine is perhaps a partner in a new single tablet regimen combination. I only want to show this and to see that there is in the future perhaps further options to treat with Doravirine, expect of 3TC TDF combination as single tablet regimen. Okay, I come to my summary, putting all this together. What can we see in the clinical trials? Okay, Doravirine is a novel next generation NNRTI. It has a unique resistance profile, but it's not a very potent drug. It has only low potential for drug-drug interactions. It is possible to use as a single tablet regimen, or as STR regimen with a once daily dosing in the 100 milligram dosage. It can be used without regard to food, and we see a consistent efficacy. It's called by the company like this, with 84% of patients reaching a viral load below the level of detection in week 48. Compared with the integrase inhibitors, it's a little bit lower, but it's not a head-to-head comparison, so it's difficult to compare with each other. We rarely see drug resistance, low rate compared with other NNRTIs. So compared with other NNRTE, it might be a very good option. In all studies, it is very well tolerated and safe. There's a low rate of discontinuations due to drug-related adverse events. Of course, it has a better neuropsychiatric profile of efferents, but I think it has also a better neuropsychiatric profile superior to the second generation integrase inhibitors. It has a better lipid profile compared with efferents and protease inhibitors, and the weight gain seemed to be similar to the average yearly change in adults without HIV. Now, perhaps my personal assessment, I want to discuss with you what do I think about the clinical development program of Doravirine, and I think it's not so nice that so far there is no clinical trial with an INST or another antiviral drug recommended in any recent guideline for the initial combination regimen in RT-naive adult people living with HIV as a comparator. You already asked, but it would be very interesting to have studies how the combination with a tough backbone as a single tablet regimen or as a regimen works, especially in the question of weight gain. I only describe you our experience so far, but it's not a randomized trial or good data. We make now an analysis of our HIV-HART cohort, and perhaps then I can present you in next year better data about the effect of Doravirine together with TAF from our cohort. But so far there is not a lot of data published about this. And another important point is this is only personal experience how Doravirine works in heavily pretreated patients who have some NNRTI mutations. So it would be a very good idea to make a study which investigates the efficacy of Doravirine in treatment-experienced patients or patients with resistance against other NNRTIs, because Doravirine should have a nuke resistance profile. There is no tough backbone for Doravirine STI. It would be an interesting combination from our point of view. And for the efficacy, the Doravirine don't seem to be the most effective drug we have at the moment. 84% is not the best you can reach at week 48. But the resistance is rare so far. But there is resistance if you compare with protease inhibitors or integrase inhibitors. In first line, we don't see any. Second line, integrase inhibitors don't see any resistance in first line studies. So at week 48. So this may be critical points in patients difficult to treat or patients with low CD4 count or high viral load. But a great advantage is of Doravirine from my point of view is the excellent tolerability, the simplicity of intake, and the low number of relevant drug-drug interactions. So if you want to have a regimen with low adverse events, Doravirine is a good option for the choice of this drug. In our cohort so far, Doravirine is mostly used in aging or older people living with HIV. So far, we decide in individuals with abnormal weight gain to use Doravirine, and we have some good experience with this. And we also use this if we have complications with other NNRTIs. For example, if you have hepatotoxicity in nevirapine-treated patients, we see that if you switch to Doravirine, you see less hepatic problems. Also, if you have neuropsychiatric problems with efferents, you have less problems. And another good point is you have no interactions with PPIs. So some people prefer to use Doravirine with riplevigine because they use PPIs from time to time. And I expect some future options for Doravirine in other STR regimens, and I also already show you some data from a dual RRT from the first phase 2 study with Islatravir, and this might be an interesting option. I'm not so sure if this is a very good option for heavily pre-treated and treatment experienced patients with a lot of resistance, but it may be a good tolerated option for our patients. So this was my introduction of Doravirine and my presentation to our first experience. We don't have so much experience, but we have some experience with this drug. And if you asked me 2 years ago, do you use Doravirine? I should answer, oh, we rarely use, but now in clinical practice, we use it much more often than I expect before this was launched in Germany. So for some patients, it seemed to be a very good option in clinical practice. Thank you for your attention, and thank you for your invitation. And I still remember your very nice conference in Mexico City, and thank you that you offer me the chance to present you this data.
Thanks to you, Stefan, because you always have time to share your knowledge with Mexican physicians. And I appreciate so much your time, and that is so early in Germany. And I think it's difficult, but you got it.
But I have no traffic jam when I go to our hospital, so I watch much faster in the hospital than regular.
Well, I think it's no more time for questions, Stefan, but thank you very much, and have a nice day.
Thank you.
Muchas gracias.